I de länderna när man börjar screena senare än vid 40 års ålder så är det risk att kvinnorna mellan 40 och 50 då, som det handlar om, upptäcker sin cancer genom att få symptom från brösten. Det kan vara symptom i form av att man känner en knöl, sekretion eller att man har eksem. Och de här symptomatiskt upptäckta cancerna, de är kopplade till en ökad sjuklighet, en ökad dödlighet och kräver också tuffare behandling för kvinnorna. Sen finns en annan sida av myntet och det är att om man inte kallar kvinnor mellan 40 och 50 så får du färre falskt positiva. Det vill säga att du återkallar en kvinna som egentligen är frisk och då slipper man att oroa henne. Jag tror att det skulle löna sig att screena kvinnor över 74 års ålder eller 75 plus. Men för att säkert veta att det kan minska dödligheten så behöver vi göra studier som visar det. Och jag har suttit med en expertpanel där vi har designat en studie och nu ligger det studieförslaget ligger hos politikerna i Stockholm som ska ta ställning till huruvida det här ska genomföras eller inte. Det är dags att screeningprogrammet reformeras. Det har ju inte förändrats sedan det infördes 1988. Jag tror att man kommer behöva individanpassa screeningen. Man kan tänka på flera sätt där. Dels kan man kanske justera intervallen mellan screeningar beroende på risken man har för att utveckla bröstcancer. Man kommer nog att behöva ta hänsyn till tätheten i en kvinnas brösttäthet. Man kan använda andra modaliteter i screeningen, till exempel tomosyntes. Så jag tror vi kommer ha en mer individanpassad screening i framtiden. I Sverige har vi ett screeningprogram för kvinnor mellan 40 och 74 års ålder. Och det är ett minimum i mina ögon att vi håller oss till det intervallet. Jag tycker att det vore rimligt att Nordens kvinnor har samma förutsättningar för tidig upptäckt av eventuell bröstcancer. Och därför är det viktigt att de också har samma åldersintervall i screeningen.
Yeah, Eva, being from Finland doesn't mean that what Karin talks about here, but the minimum of requirements, it's 40 up to 74. What do you think about that?
Well, I definitely think she's right, and actually the EU Commission has now very recently last year provided a recommendation for enlarging the age scope, either to start either going down or upwards in age. I think this is really, really important, but of course it's also very important to follow how women participate. And I think in Finland we have been really strong on trying to follow up on having a register and clearly following up on the results and how women participate. And we see that there are issues with particular women. In particular, if you women living in cities, for instance in Helsinki, the rate is much lower than elsewhere. I think we have come down only to 73% participating because everybody are invited between now 49 and 60, between 60 and 70. But they are not participating that much. We also see that women outside the workforce participate less and women with different mother tongues. So I think we need to enlarge definitely the age scope, and I hope, and for instance, we have many times suggested that we would enlarge it in particular to 74-year-olds or under 75, but we also need to improve the participation so that all women are actually feel that they need to go when they get the invitation, and we need to follow it up and think about why they are not perhaps participating.
Yeah, but you also do, it's not just only the participation that you look at, you also have a discussion in Finland to
enlarge the scope of invitation to the screenings, of course, yes.
But also the age range, that you talk about it, that you want to have it, or is it in discussion around
I think it's in the women's movement, but I think there is in the health ministry, they are sort of doing some kind of cost-effective analysis on it at the moment, and I think it's going to be published very soon. But of course, it's not only the experts deciding; it's the politicians. And at the moment, we have a government negotiation or coalition negotiation going on, and already I see that gender equality is not that high in the agenda as in the former government, who was really strong on that. So I'm not sure.
Work to be done there.
Yeah, I think we definitely need much more pressure at the moment.
Yeah. Nora, what does it look like in Norway?
Yeah, so like you mentioned, the current age group that's being screened is 50 to 69. But what we do have to do is we have to look at the updated recommendations from the World Health Organization. And right now, that decision is with the Directorate of Health that is currently looking at whether or not that should be expanded in our country. And I think it's important to keep in mind that these decisions should be data-driven, and that we need to look at the evidence for it, and we need to look at the studies that have been done, and also keep in mind that we should have equal terms in the Nordic countries and look to the World Health Organization to make these decisions. So right now there is the discussion, should we expand it? And it's being done currently in the Directorate of Health, which is then going to be discussed in the Ministry of Health. So there is movement being seen now in Norway, but I think it's important to make sure that these processes are data-driven and that we are looking at the best available evidence that we have.
Mm. But Catherine, do you recognize what they talk about from Denmark?
Yes, I do. And I also recognize that it's at 69, it's like we stop here because older women, what should we do with them, really? They can go die. Because isn't it right that at 69 you might still be part of working force? And this is really what it's about, isn't it? That you invest in women's health as long as you can provide them into the economy because they are working. But if they're not working, well, then you are not giving that much attention. And basically, you're really not in this area giving women attention. I mean, because you can see from the 6.6 club, what was just mentioned, that we are still looking at women in all our Nordic societies as somebody who basically should provide children. And that shows also in that aspect that you could actually help people, women, when they are bleeding or they are having other symptoms that comes from being a woman and not a man. And still, we are not really helping them to go into work those days when they have that pain, because we are not really part of the working force. We are part of those who are providing back home the babies still, and the house and the caring. And I think that is a basic problem still in Scandinavia, although we are supposed to be the most equal countries in the whole wide world. I do think not.
Mm. You do think that it is a little bit, that the feeling is that we are not needed after a certain age because for the economy.
Yeah, we are, so exactly, and not even while we are in our prime as also working force, we are still not really taken seriously, because they are not. But 1%, we just heard it, 1% are investigating into women's health. That means that there is a lot of money and a lot of bias to the rest of the research in medical care. So I pray why. It must be because we are looking at women very differently, basically. We are still seeing all of us like the Virgin Marys, really. I am the vicar here, so I can say that, although not Catholic.
But if we would be healthy, if we get the help, we could also be healthy longer time and also stronger, so we can do a lot of work then. So if we just get the help. Susan, we have up to 74, but you are not really happy with that. You are a little bit more with what Karen said, right?
Yes, definitely. I do agree that we do have to have data-driven evidence, but what we are looking at the moment is something called endpoints. Endpoints with mammography, they look at mortality. And we cannot, in the higher age, look at mortality. We have to look at quality of life. We have to look at also life expectancy of the women. The women of today is not the 70-year-old woman she was in 1988 when the mammography program was introduced. So we have to rethink. And another what people think, or a profession also think, is that the tumors of elderly women are not as aggressive as the younger women. That's not true. It's the same tumor, it's the same component, it's just as aggressive as the rest of the age groups. So when you are 75, you're not being screened anymore, and you get a tumor, you don't detect it, and because you don't go to mammography. So at the point when you know, when you have the symptoms, just as Karin said in the video, when you have the symptom, the tumor is already so large that you have to have very invasive treatment. That means not only surgery, you have to have chemotherapy, you will probably chemotherapy, you will have to have radiation, and you can all think of how you will feel when you are maybe not as strong as a younger woman and you get all that treatment. And before, that's the tricky thing with breast cancer. You don't really feel sick when you have breast cancer. You get sick of the treatment. So if you get an early detection, you get a mammography when you are 76, you are a fit woman, you take it out, you may get some, tablet therapy or radiation, but you don't need the chemo, and you can get out of that treatment not healthy. Of course, you have some issues, but you will have less invasive treatments and feel a lot better than with chemo. So that's one of the things. And I will also say that there are, let's say, out of 100,000 people that go to mammography, 46 of them die in the age group where we have the mammography between 40 to 74. In the age group over 75 to 89, in one of our regions, or for the whole of Sweden, it's 120 women that die. It's more than double, and that goes for region by region by region. There is no exception. So, I mean, these are numbers that we have from the National Board of Health and Welfare. It's nothing that we just come up with. It's a fact. And I think that fact speaks for itself.
Yeah.
And we do need some studies, of course we do trials and to confirm and stuff like that. But we know this. We already know this.
Yeah, we have it. We have it on the paper. So, Christine, do you same age range as in Sweden? Do you recognize this?
Yes, we have been having this for quite a while, from 40 to 74, and of course the reasoning being the evaluation has been that the younger cancers between 40 and 50, we want to get them before they have the symptoms. They are traditionally the younger, more aggressive, and so those we want to catch, absolutely. And concerning the older group, traditionally the evidence has been evaluated that they are less aggressive and they answer more to the hormone treatments, which is a great help to be able to take the tamoxifen. But we always need to reevaluate and look at the data and rethink things through, because with increasing use of hormones and that affects on then these issues. So we need to keep looking at it, but I am absolutely in agreement, and the colleagues that I've spoken to, that 40 to 74 is extremely important. And then we will additionally be having personalized medicine. We'll be looking more at the genetics, more at the other risk factors, and it's not just the BRCA1 and 2 that's been spoken of concerning the genetic risk factors. We now have almost 200 markers we can be looking at, and so then we might have subgroups that might be looking at even earlier and even later, and I think that will be a way forward. And the EU has now is recommending 45 to 74. So my recommendation would be to my colleagues, the 3 countries in the north, to definitely start earlier, and that we share our knowledge and the rethinking and reevaluation.
Eva,
may I add, because I think they were so marvelous, your points, and I think one very important point is, as a politician, because we usually say we have to do this data, it has to be fact-based, but what you said exactly is what are the costs we are evaluating? Is it that you are, part of the workforce, or is it your healthy days as a active human being? And if we look at our societies, elderly women, they are part of the workforce, but they are also doing a lot of other stuff in society. I mean, look at culture. Who is keeping the whole theaters and everything, alive? It's actually the women. Who is active in the NGOs, in the voluntary work? It's the elder women. So, I mean, it's not only a life value for ourselves, which of course should also already be enough, but I think we also look in a very narrow way on the cost-benefit analysis. And I think exactly as you said, there's really so much good life that could be there for us if we would be having a good care early enough. So I think it was really valuable what you said.
And also the cost for helping women to keep their health, or paying having a cost when they get sick. It's kind of
and just being active and participating.
And even expounding on that, if I may, I think it's women of all ages.
Of course.
And care has been either not evaluated in the economy or GDP. Care and compassion and the power of what we have in abundance is kærleikur, is kærleik, is love, and there are studies looking at that component. It's either been totally taken for granted or underpaid in these countries that pay for such work.
Yeah.
So that's something that women can
we're gonna say a little bit more in the medical part of the breast cancer, because there is also an issue with dense breasts, which is tät bröstvävnad, that Karin mentioned briefly. Just to explain to you who not really updated with this, the problem is that dense breast tissues appears in mammographs as white, as the same as a tumor. So therefore it means that there's a higher risk of false negative results and also delayed diagnosis for women with dense breasts. And I know that, Susan, that Swedish Breast Cancer Association have been advocating individualized screening to overcome the problem with cancer in dense breasts often goes undetected. Right. So can you tell us a little bit more what you have looked at?
Yes. So women it has nothing to do with firm breasts. Mm-hmm. It has only to do with inside the breast. So as Christine said, when you have dense breasts, a mammography cannot detect the tumor from the rest of the content of the breast. So what we do is we want all the women to go to mammography, as many as possible, but we do not distinguish those because we know when we see the mammography picture, we know who has dense breast and who has not. But we do not tell this woman, oh, I'm sorry, you have dense breast. We have to send you to an additional complementary screening. No, we say thank you, and you can go home, and then you get a letter in your mailbox that says, "Oh, it's good. We didn't find anything," because the national board, Socialstyrelsen, have no guidelines for dance breast. What we want is that these women can go to additional screening, because we have ultrasound. It's better. It's not good, but it's better. We have tomosynthesis, which is a kind of CT where it goes around the breast and makes multiple pictures. And then we have MRI, which is also a very good screening. But there are no guidelines for this. So these women that have 5 times higher risk to develop breast cancer also, despite of that we don't see them, they don't get the mammography that they deserve. And besides of that, they don't get to know that they have dense breast, because there are no guidelines for that either. So some of the women in Sweden do ask now when they go to screening, so do I have dense breast or not? And sometimes they get an answer, sometimes they don't, because...
But you can see on mammograms that you have dense breast, right?
You can see that on a mammogram, yes. So the first mammogram you would go to, there it should be established. You have you use BI-RADS, A, B, C, D. So if you are in the group that is C or D, especially D, you have the most dense breast.
What would happen, do you think, if the next time they will be called to mammograms, instead also got a screening, because you know that they have dense breast in another kind of way, the tomosynthesis. So instead of coming back and do the mammograms again and not maybe being seen, if they can get the chance from the beginning when they know.
Yes.
What would you think would happen then?
Yes, well, if you detect that you have a very dense, let's take the D group, you have very dense breast, you detect that when you're 40, you go to the first mammogram, so you will be sent to an additional screening, and next time that you will be going, you will be sent to the right sort of screening. And this is the risk assessment that we were talking about a bit earlier. Yeah, what I was saying about we don't even know that we don't get to know that we have dense breast. So we were talking earlier in the panel about the voting rights for women, which was something in the 1920s. But in
1906 in Finland.
Yeah. Well, in Sweden, 100 years later, we're not, trusted with being able to take this message, you have dense breast, because we might worry too much. So I would worry more if I knew that my tumors are not showing. And I mean, it's not that many. Not many women get breast cancer if we look to the big group that go to mammography. But do we really want these women lost? Because we can't take the message that we have dense breast.
Yeah. And it just feels like it's not a big work to do to change that kind of registration for women to get to know that they have dense breast, and they have a chance to next time go to another screening, which can see the tumor or not in another way. It's not that big of a science to change, I think. Or what do you say, Catherine?
I think this is actually a nice picture of what the problem generally, because now we are having screening of women's breasts. Tick. And go do it, right? You could research further into that and then make it better, even. It is 100 years ago we got the right to vote in the Scandinavian countries, give and take, right? And today we still have such problems with giving equality to women, also in health, and it means there is something wrong, and it might be, I'm sorry to say now, something that might not enlighten our good spirit and humors, because 100 years ago it was mainly men in the Scandinavian countries that insisted on we having the right to vote. It was not mainly women. So could it be that today we women has a special obligation to go forward on the topic of research and economics into women's health. We cannot sit on our flat butts and say, let them all do it for us. We have to say something ourselves. We have to vote for those politicians that are wanting to do more for the cause of women's health. We have to do it, not just the men. We women has a special obligation.
Eva?
And I think this is really right. I think for the moment, actually, there are big political trends also in the Nordics and in Europe who actually don't want us to talk about gender sensitivity in health or in any area. And there's a lot of this kind of what about the men and what about the boys, immediately as if something would be taking away, from the others, as if there would be two opposite groups. And I think this is very important to be aware of, because politically it's not a very nice era at the moment. I think we are not going so fast forwards in women's rights and in gender equality as we should, as we have been doing for a while. And I think we need to talk about it more. And I think, and the same goes with expenditures on health. And we really need to be able to prove that it's worthwhile to put in these screenings, because the screenings are expensive, not because, of course, that one screening is so expensive, but because it concerns so many. So it's a big investment for healthcare. But of course, it doesn't mean it wouldn't be worthwhile, because, of course, it's much more expensive to have people being ill, having to be taken care of much more. So I think we need to talk about this. We need to be very systematic and political about it. I agree with that.
Yeah, and it's very important. And then one thing that she, Karin, said was also about this, to come back to this, is expanding and thinking of this resources that we don't have. It's limited, so it's hard maybe to range the age, if we come back to that, because they don't have the resources to the nurses and everything to take care of it.
But they are very effective nowadays,
They are. They are very
it's amazingly
effective.
Quick.
Yeah, but what do they talk about that in Norway?
Yeah, I think an important point is that as the population gets older, there's more demand for healthcare. We're only going to get sicker, and we're only going to get older. So there's always going to be an increased demand for healthcare. I think the importance of screening is only going to get bigger.
Yeah.
Right.
Yeah.
I think preventative healthcare is only going to become more important, and in a cost effectiveness perspective, I think screening and prevention is always going to win compared to treatment, right? So I think it is important to keep that perspective in mind, and it is only going to become more and more important to screen and to be effective with prevention on a public health scale, but also in like prevention and secondary prevention. And I think for us, the government isn't quite there yet. We're still, our perspective is perhaps too narrow. We're thinking of the current fiscal budget. We're thinking of next year's budget. We have the hospitals have specific budgets they have to stay within, right? But I think if we keep a longer perspective, 10, 20 years, I think that, screening and prevention is the more cost-effective usually option.